Hi, I'm Azra Ismail, a final year PhD student in human centered computing at Georgia Tech. I'm excited to present our paper today on imagining caring futures for frontline health work. This is joint research between Georgia Tech and IIIT Delhi with my co authors Deepika Yadav, Meghna Gupta, Kirti Dabas, Pushpendra Singh, and Neha Kumar. Care work and workers are increasingly a focus of study in CSCW. A workshop in 2018 and another last year brought together scholars around this topic, spanning a wide range of perspectives on care in both formal and informal settings like nursing, frontline health, social welfare, volunteering, education, and more. These discussions drew attention to the digitization of care work and the critical need to understand how technology use can shape and is shaped by care. Conversations on care work have also entered public consciousness during the COVID-19 pandemic, as the gendered and underpaid nature of care work has become more visible. But even as significant investments are being made in digital technology for care workers themselves have remained chronically underpaid. Care work has historically relied on women from minoritized and marginalized backgrounds, and workers globally have raised their voices against their exploitation during the pandemic. Our paper examines how care workers carefully navigate digitization, precarity, and complex social relationships in an attempt to care for their communities and each other. We also consider the conflicts that tech researchers and practitioners may have to grapple with when designing technology in care settings and chart potential paths forward for the future of care work. Our paper analyzes an emerging digital ecosystem for frontline health workers in India during the COVID-19 pandemic. We focus on accredited social health activists, or ASHAs, in the state of Haryana and share data from remote interviews with 18 ASHAs over two phases of the COVID-19 pandemic. Ashas are women frontline health workers, typically from low to low middle income households, who are tasked with providing reproductive, maternal, and child healthcare at the last mile and attending to primary healthcare needs in general has happened during the pandemic. There are almost a million Ashas across India, and their work is increasingly going digital and now entails a number of mobile applications that have been provided by the state for financial compensation, data collection, and surveillance of digital workflows. They've also been using WhatsApp for coordination and Zoom for virtual training. Finally, ASHAs have been recruited to varying extents to support with the implementation of other digital health apps, such as Covin for vaccine registrations and Arogya Setu for contact tracing. We found that the digital workflows of ASHAs were implemented top down, frequently aligning with the interests of the state and supervisors. These workflows were shaped by and influenced also the social organization of care, or the systematic ways in which care is allocated and how responsibility for caring labor was assigned. We also examined the labor politics within which care work was embedded and the precarious nature of the work. I'll now share a few snippets from the field to provide more context around how these various perspectives interconnected. So we found that Arshas were engaged in various forms of caring labor due to perceived duties towards and societal expectations from the state, their families, and communities. These perspectives could come into conflict with each other. So, for instance, Preeti shares, when we used to visit houses for surveys, people were fearful of being taken for isolation. What if the Asha tells and they send someone? This fear created a problem for Ashas. I had to explain to families that it's our duty to report the data. You're not filling any false registration for corona positive for you. Don't be afraid, you will get free medication. Saying this gave me the data. Ashas saw these COVID surveys as a duty both towards the state and their communities during the pandemic, even though this put their own and their families' health at risk. And they provided assurances to community members so that they could do their work and get paid, even though the community members actually had valid concerns and some had been traumatized by the isolation procedures. We also found new forms of organization among Ashas that came up to fill the gaps left by the state. CARE thus served as a resource to build community networks to enable digital transition. For instance, Manushi shares that the problem with Zoom is that it does not work if 1,000 members have joined the meeting. Niyasha could not attend the meeting sitting at her home. So all the Anganwadi workers, who are another kind of care worker, teachers and ashas, used to sit together and attend the meeting. If someone is able to join the meeting using the meeting ID, then rest all used to sit around that person. We also found that financial compensation had also been digitized, and ASHAs demanded transparency in these data flows. So, for instance, Sunita shared, Madam, we should also have the option on our phone to check the payment received monthwise. The app has no details about who we received the money from, the amount, and when we received it. Shouldn't all of this be there as well? If you're asking us to use phone for our work, then we should have details about our money in it as well. Finally, we also found ASHAs actively resisting worker surveillance and control. This was particularly visible in the case of an app called MDM 360 that was described by Mamta as follows. If an ASHA worker uses the internet too much, that information will now be made available to the block coordinator. And if a supervisor wants, she can restrict access to any mobile app like YouTube, Facebook, etc. Our phone will only run those apps that our supervisor wants us to use. Given such tensions, a key question for tech researchers and practitioners is how do we support care work amidst worker exploitation and co-option of digital tools for state and corporate interests? Our analysis uncovered several approaches that workers were already taking to enacting care for their communities and for each other. We call these care orientations, taking inspiration from feminist and queer scholar Sarah Ahmed, who says, to be oriented in a certain way is how certain things come to be significant, come to be objects for me. We draw attention to four interconnected ways in which workers oriented themselves towards care by directing their efforts towards survival, resilience, advocacy, or resistance. These varying orientations could sometimes come into conflict, or one orientation could even lead to another. These care orientations could also be adopted by researchers and practitioners to critically reflect on and direct technology design towards enabling more caring futures for and with workers and communities. So, in terms of survival, this entailed working within the system to maintain their livelihoods and to ensure that families and communities were safe and insured against harm and illness. It was evident, for instance, in their efforts to provide care during the pandemic, even though this came at the risk of personal safety. We also found workers working outside, but still with the system to create and maintain community resources to provide each other with support when experiencing adversity. And this was evident in terms of how they helped each other to use new apps and navigate limited digital access. Health workers also advocated to change the system by raising voice against oppressive structures. Many ASHAs organized strikes and protests as part of the ASHA Workers Union to surface their voice and perspectives, such as through demands for transparency in data. Finally, we found that workers also actively resisted the system to dismantle or replace oppressive structures. This was evident in their refusal to use the MDM 360 app that monitored their use of the phone and successfully getting it recalled by the state. Given their relative privilege, researchers can lend their support to these efforts. But we also found that advocacy and resistance could come up against an orientation towards survival by impacting their livelihoods if the state choose to retaliate. So we urge CSCW scholars to really critically reflect on their roles in such politicized care settings, given the possibility of such consequences. With that, I reach the end of my presentation. Thank you for your time.